Good morning, remote attendees. We will be starting the meeting in a few minutes. I apologize for the delay. We are ready. Yeah.
I didn't need to use the gavel, but I never, ever miss an opportunity to do so. Good morning, everybody. We're going to call to order the meeting of the Finance Committee of the Cook County Health Board of Directors. If you'd read the roll.
Director Green is absent. Director Harrington?
Present.
Director Lowry?
Present.
Director Robinson?
Present.
Chair Ryder is absent. You have a quorum.
Thank you. Do we need a motion to allow participation remotely for members of the board?
We do not have any members who are remotely connected.
Great. Before we begin public testimony, I'd like us to take a moment to recognize Terry Garland, who made his transition on June 29th of this year at the age of 67. He had served as head electrician at Stroger Hospital, retiring in 2022 after almost 30 years working within our system. He was essential both as a leader in the organization and also for supporting our board, the functioning of same, as well as he was a conduit for the public for many years. A proud member of IBEW 134 for 43 years. His father had been a member of IBEW 134 as well. He leaves a legacy of hard work. He was a great union man, and he always led by example. He was always willing to go above and beyond to help anyone who needed it. He was a friend to many here at CCH, and he will be missed. Condolences to his wife, Diane, and to the rest of his family, including his children and his many grandchildren. So if we can now just take a moment of silence in memory of Terry Garland. Thank you. Public testimony. Is there anyone registered to provide in-person or virtual oral testimony, or do we have any submitted written testimony to be included in the record?
We did not receive any registrations nor any written testimony.
Thank you. Deb, I want to acknowledge you and thank you for making this as turnkey as possible.
Thank you.
Action items. The June 5th, 2025 Finance Committee meeting notes. They were approved at the June board meeting. They're being presented for the committee's review and discussion if necessary. Are there any corrections to be made to those minutes?
None here.
Hearing none, seeing none, is there a motion to accept the Finance Committee meeting minutes for June 5th, 2025?
So moved.
Is there a second?
Second.
All in favor say aye.
Aye.
All opposed? In the opinion of the chair, the ayes have it. Items under Chief Procurement Officer, action items, contracts, and procurement items. We have 25. Am I kicking this to Charles? Charles, the mic is yours, my friend. Good morning.
Good morning.
I'm sorry, audio trouble here. Marley Hendricks, Director of Public Health Administration here. So this first contract, sorry,
Marty?
oh, yeah.
Sorry, Charles was having an issue with his mic. I think it's fixed. Charles, did you want to
Okay.
do the intro before Marley
Yes.
starts?
Again, Charles Jones, Chief Procurement Officer. Today before you, we have 25 items. 22 of those items require responsive letters from Business Enterprise Development. We have 13 back, 9 are in process. And with that, we'll go with the executive sponsors, the Department of Public Health. Request 1 through 3 is Marley Hendricks.
Sorry for jumping the gun there, Charles. Good morning, everyone. So the first contract you have before you is a request to increase contract with Clarity Partners, which is the vendor that supports our website. The request is not to exceed $200,000 through fiscal 2026. And the intent here is just to modernize and support our current website. Any questions here?
No questions.
Thank you. All right, next, what you have before you is with contract amend, extend, and decrease with the University of Illinois Chicago. So this is unique. It's a request to decrease the contract in the amount of $120,700.77. This is due to the suspension of the CDC grants that previously supported this work. We are continuing the work supported with corporate dollars, but we are adjusting the contract to mirror our fiscal year. So this takes us through November 30th, 2025.
I have a question. It's a general question. What unit of the University of Illinois Chicago are you working with? System.
So this is a unit that supports evaluation for community health workers. So it's a vendor that helps support training with community health workers.
So are they a unit or department of the University of Illinois, or are they subcontracting these services?
No, it's a part of University of Illinois.
You know what department?
Not specifically, but I can circle back on that if you'd like.
Please proceed.
Alrighty, thank you. Any other questions on this particular contract? Okay, all right. And so I have one more before you that is another request to amend, extend, and decrease. Same rationale as before. CDC equity grant was suspended as per CDC guidance this year, and so we are continuing the work but supported with corporate dollars. This request is a reduction of $17,375.05 to align with our fiscal year. And this contract is with, Housing Helpers through Proviso Partners in Maywood, Illinois. Any questions on this one?
Request 4 through 7, Health Plan Services.
Good morning, directors. This first item before you is an increase to our contract for our HEDIS services vendor. This covers our HEDIS data submission to the state and supports our NCQA quality rankings. Total amount is $211,000. The next contract is for our Prescani Associates. This is for an increase of $648,000. an extension through November 30th of 2026. This provides a number of different surveys that we do across the plan, including member and provider surveys, and is also including a lot of new auditing that we're doing across our provider directory around appointment availability for our members. This next contract is a one-year extension for $391,000 for Centauri Health Solutions, which provides SSI and SSDI member eligibility and enrollment for individuals in our health plan who qualify for this program, where then they receive additional supplemental income and also are eventually able to move on to Medicare if their health condition allows. And then the last contract I have is a 3-year contract for $2.9 million. This is for consulting services across a number of different accreditations that we're pursuing as a health plan, including our health equity accreditation, a long-term services and support accreditation, the renewal of our NCQA regulatory accreditation, as well as some support across a few different projects we have with HFS, including our annual report submission and the upcoming State of Illinois RFP. I will note this is certainly a max dollar amount, and so the actual cost will end up being the time needed across each of those projects. And we're expecting to be able to manage the cost lower than what's presented here, but this is going to just depend on when all of those different projects hit and the timing of those. So we just want to ensure we have adequate resourcing across the teams during those different items. And with that, I'm happy to answer any questions.
Yeah, I'm assuming that this entity actually helps us achieve some of the star ratings that we get. Yeah, I mean, that they're integral to our work in terms of how we're measured, how we're monitored, and pointing out things.
Yeah, that's correct. They would also include some of the data development for, especially around the annual report submission. That includes a full review and breakdown across a number of different quality measures that leads up eventually to a submission to the State of Illinois as well. But part of that includes that data and some of the underlying work planning around some of those measures as well.
Is there a way to quantify the value of what they do? If not, I understand. I was curious.
Not in a really straightforward way. We would be able to kind of evaluate where we're at on some of those particular measures and then how we execute on some of those work items over time to see the impact. So we could do that on some like specific measure by measure items.
Yeah, that would be anecdotal, but I think it would be helpful.
Yeah. Thank you.
8 and 9 is clinical, with 9 being jointly with clinical and operation and development.
Good morning. Lauren,
Morning.
Chief Medical Officer. This contract is for an increased contract with a biomed for specific product and pellet catheters, not to exceed the amount of $1,511,111 through the current contract end, which is March 14th, 2026.
Good morning. Adam Weber, Executive Director of Special Operations. I'll be sitting in for Craig today for his item. So this next item is an amend, extend, and increase contract with Intuitive Surgical. It's a 7-year contract worth $8.8 million. We are going to be adding the DV5, which is the latest surgical robot made by Intuitive. We're adding this to our fleet of 2 XI robots and an Ion robot today. This will keep us on the forefront of robotic surgical technology.
I have a question.
Yes.
I would like to understand how this addition will actually improve the lack of productivity that we see across both hospitals and surgery.
Absolutely. Yep. So we've got the 2 XI robots in place today. So we have a lot of good data on that of how we've done that to date. And then adding this will just add to that. So we'll get some information back to you after the meeting.
Right. So to be clear,
yeah,
when we look at how we have the deficit, that we're not hitting the budget in that area from the revenue standpoint.
Sure.
So at one time, and I don't expect you to be able to answer this question, but I want to make sure the question gets answered. It was stated that we needed to hire some more surgeons. We hired the surgeons. The numbers did not go in the right direction. So my question is, how will adding this piece of equipment impact that direct number?
Understood.
Okay, thank you.
Thank you.
Thank you. 10 and 11, communications.
Good morning, Alex Washington, Chief Communications and Marketing Officer. These two contracts are for PLCCA and ATW to serve as our partners in community outreach efforts. This is a dual award selected via an RFP for 3-year contracts with 2 optional 1-year renewals. Their staff are extensions of our outreach team and represent Cook County Health and County Care at events in the community, including redetermination events, where they help Medicaid members complete their paperwork. Last year, we participated in 560 events, and we're on track to exceed 600 this year. The contracts are each not to exceed $360,000 through June of 2028, and I'm happy to answer questions. Thank you.
Number 12, finance.
Good morning.
Good morning.
Curtis Haley, Chief Revenue Officer. This request is a increase request for Great Lakes Medicaid. They assist us with our Medicaid application denials and assist patients with aligning with Medicaid and different state programs. The request is to increase the contract for this fiscal year as needed.
Request 13, Health Information Systems and Operation and Development.
Thank you, Charles. This contract is an extended increase contract with Centec LLC over 3 years for $93,313.47. Centec provides environment of care rounding software for us. We've done licensing and training with them, and we use this software to maintain that EOC rounds data across different disciplines across the hospital, and then are able to use that information to with regulatory bodies and to ensure that we keep the hospital where it needs to be. Thank you.
13, Life Science.
Good morning, Mark Spranka, Chief Scientific Officer. This is a request to increase the amount of $10 million to MEDICS. MEDICS serves as a temporary staffing location for the folks that were formerly at Hectone in grant-filled roles. This increase contract will enable us to have the time necessary to prepare offers to eligible staff so that we don't lose any of the folks while they're at MEDICS. Importantly, once we've gotten them transitioned, we will be able to bill the sponsors and get reimbursed for most of these costs. Any questions?
All right, thank you. 15 through 19, Operation and Development.
All right, getting some steps in. All right, this next contract is an increased contract with Granger, 4 years for $8 million. Granger provides us with maintenance, repair, and operational supplies to the Department of Buildings and Grounds. We also use them for some minor repair work as needed, but this adds $8 million over 4 years. Next contract is an extended increase contract with Orkin LLC for 2 years for $555,000. Orkin provides regularly scheduled pest infection services across all of the CCH campuses, and we also call them ad hoc as needed for any pest control items. Next is an extended increase contract with Pickens & Kane Moving and Storage for $300,000 over 2 years. Picks and Kane provides us with warehouse handling, inventory reporting, storage. They also deliver furniture, fixtures, and equipment for installation across the CCH facilities. And they also assist us with any building moves that we do for our staff as we move across different buildings. Next is an extend and increase contract with Markey Life Safety LLC. This takes us through August of 2026 in the amount of $209,250. Markey Life Safety provides us with accreditation processes, including accurate life safety drawings, showing various safety elements of the building. They also assess all of our fire systems, including the just under 1,700 fire doors across Cook County Health, and also an additional 186 access fire doors across the system since we first went into this with them. This is first of two renewal options we have with Markey Life Safety. And the last item I have for today is an XU contract with Pamela Smith in the amount of $250,000. Dr. Smith provides us with a unique medical skill set in the adult and pediatric medicine space. She works across the ACHN facilities. This is an amount not to exceed. We use her services as needed where we don't have those services elsewhere within our ACHN physician leadership group. Any questions on that group of contracts for me? Thank you. Thank you.
All right, request 2224, Georgia Hospital.
Good morning, Donica Austin Kathy, Chief Hospital Executive for Stroger. The first one before us is an extend and increase contract with Syncora for prime pharmaceutical distribution services in the amount not to exceed $100 million. The revised contract period of 10/1/2025 through 11/30/2025. The vendor will continue to provide pharmaceutical distribution services, and this is for the entire health system. The vendor is one of 3 national pharmaceutical wholesalers approved by the system's GPO, and an RFP or RFQ is currently in process.
Is there an anticipated cost savings for us? We're spending $100 million, and I assume there's a return on this investment in terms of savings.
I don't have that information.
So this current contract has an 8.25% cost minus discount.
Thank you.
Thank you. The next one is an extend and increase contract with Global Imaging Specialists for remote diagnostic radiology services in the amount not to exceed $998,705. The revised contract period of 2/2/2025 through 2/1/2026. The vendor will continue to provide professional services for the radiology department, clinical support, and remote diagnostic interpretation. The next one is extend and increase contract with West Physics Consulting for the radiation safety professional services. The revised contract period of 3/1/2025 through 11/30/2025. The vendor will continue to provide the medical physicists as per the state regulations, the system's hospital radioactive materials and radioactive producing equipment, must sustain the services of our radiation safety officer and the laser safety officer. And next we have a request for an expenditure approval. This is for vendor Agility Healthcare. Back in June of 2023, there was a need for purchase or brought on a new rental stretchers. And there was an increase in the census during this time. That was what prompted the request. So this request respectfully is for payment to resolve the outstanding invoices, as well as a buyout of the beds that are needed. And the next one is for Favorite Healthcare Staffing. This is for invoices for the services of a registered respiratory therapist during the time of the pandemic. So the invoices were going to a specific division, and now they have gone to the right place, and we are working to resolve and get these invoices currently paid. Okay, thank you.
Item expenditure 25, health plan services.
This item represents a final payment to vendor First Transit. This is for claims payments to transportation providers. This is the final payment for run out of claims after the end of the contract term. We changed vendors due to an RFP process, and so we're now working with a new vendor for transportation services, but this is all the claims that relate to pay providers with that previous vendor.
Thank you. Is that it, Charles?
Yes, sir.
Thank you. Is there a motion to approve the 4A contracts and procurement items containing request numbers 1 through 25, subject to completion of review by the contract compliance group?
So moved.
Second?
Second.
All in favor say aye.
Aye.
All opposed? Opinion of the chair, the ayes have it.
Thank you.
Thank you. For 4B, report of emergency purchases, there will be no report at this meeting. And we'll now move on to item 5, items under the Chief Financial Officer, presented by Scott Spencer, Associate Chief Financial Officer. Scott?
Hello, good morning.
Good morning. These will be the receive and file grant award related items.
Yep. All right, so looking at this month's report, the receive and file grant awards, just over $7 million. Just highlighting a couple of the higher dollar awards, the AMA for $364,000, and then the $3.7 million grantor being IDPH. So any questions on that?
No question.
Okay, so we'll move on to the next slide, please.
I believe we need a motion to receive and file.
We do. So there are no more grant award related items you're gonna address at this point, Scott?
No more.
Okay. So given that, I would like a motion to receive and file the 5A grant award related items.
So moved.
Second?
Second.
All in favor say aye.
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 All opposed? Opinion of the chair, the ayes have it. Now, Scott, we'll go to 5B. Action item is receive and file transfer of funds.
Yes, thank you. So requesting a transfer this month of $20 million from the managed care claims line to professional services, which is associated with the health plan membership being above budget and thus creating some additional expenses on the administrative side, specifically TPA expenses and benefit manager related expenses.
Any questions? Hearing none, seeing none. I'll now take a motion to receive and file item 5B, the transfer of funds.
So moved.
Is there a second?
Second.
All in favor say aye.
Aye.
All opposed? The opinion of the chair, the ayes have it. Item 5C, May financials. Scott?
Yeah, so we have the financials here for the first 6 months of the year. So coming in at 66.1 million unfavorable on an accrual basis and 86.4 million unfavorable on a cash basis. The drivers remain the same as they have been over the last few months, which is net patient service revenue continuing to be unfavorable to budget due to lower than budgeted volumes and increases in charity care, However, capitation continues to be favorable. County care coming in at 22.6 million unfavorable on a year-to-date basis, which is about $1 million different from where they were a month ago. Membership remains strong at 414,000. So the income statement here, again, just to reiterate a few points here, the adjusted NPS are unfavorable by just under 85 million. But as we add in the favorability on the capitation line, total revenues are favorable by just under 58 million. Dropping down to the expenses, total expenses unfavorable by 120 million, which is comprised of the medical claims expenses being unfavorable by 185 million. But then some favorability on the salaries and benefits line of about 69 million due to the open positions. Next slide, please. So a bit of
Scott, I'm sorry, can we go back to, go back 2 slides, I think? Yeah. On county care, it says 22.6 million unfavorable budget driven by medical loss ratio of 1.4, but then you said that the census is still the same?
No, sorry, the census.
As far as the membership of county care?
Membership is favorable, favorable to budget. But at this point, there is an operating loss due to the medical loss ratio being higher than anticipated. In other words, claims have been running higher than expected.
Maybe I asked this question. Do we know why?
So Aaron can provide a little more on what he's walking up. I think one of the main contributors, there are high dollar, sorry, I can take a guess. Okay. There are high dollar medications that really haven't been baked into the state's compensation on the cap. So the spend is actually ending up higher right now than the actual capitation that we're receiving on the revenue side. So Aaron,
so that's the same issue that we've had before?
That's correct. Aaron Gleaner, Chief Administrative Officer with Health Plan Services. So a few things just underlying these numbers, the high cost drug medications that we've talked about before. That expense is baked in on the expense side right now. The state has developed a process that they're going to reimburse health plans for some of those high cost drugs. We have not baked in any of that reimbursement into the financials yet because they haven't fully laid out exactly what that process is going to be so that we can put a good estimate on that. But we expect that's obviously going to help. We just, here at the first part of July, also got our retro payments for rate adjustments. A lot of that is already estimated and baked in. Those came in a little bit higher than we were expecting, so that's going to help a little bit in these numbers. And then, you know, I think just some other comments, a couple other things we've seen is general acuity in the population has been relatively stable. We do suspect that, and this is more anecdotal at this point than data-driven, that we've seen some members, because of the HPIA loss of coverage, that have been seeking out care ahead of that loss of coverage. So we think we're seeing some of that expense hitting here in the first half of the year. The final thing I would note is that one area that we see some differential based on expenses that are expected versus where the state reimburses is on high-cost NICU cases is the other area that we've been monitoring very closely, and that also seems to be an area that we have more NICU cases than other health plans. That's likely at least partially contributed to the network we have. So because we have Northwestern and University of Chicago in our network, and not all MCOs do, more of those cases are obviously concentrated at those type of facilities. So that's something else that we've been monitoring and are also starting to have some conversations with the state around.
So are you saying with those two entities, are you seeing more people there, or the costs associated with those particular ones are higher?
Both, because they have both have level 4 NICUs. You know, we just see some of the worst NICU cases centralized at those hospitals in our plan because they're in our network.
Do we think that there's an increase in those as far as the membership is attracting more people that have those particular problems?
It's not, I wouldn't necessarily say it's a increase, just when we look at the amount of funding the state provides for that particular population. So the rate cell they create the revenue estimates for is the 0 to 3 month population and the family health plan program. So for FHP members, 0 to 3 months, the amount of revenue that they provide MCOs. When you look at that across all of the MCOs, the funding is kind of is enough in total, but there seems to be some significant discrepancy between how much of the expenses we incur as county care versus the other MCOs. Typically, that would play out in risk adjustment, is the way the state would correct for that, but they don't do risk adjustment on that 0 to 3 month category, and just because of the uniqueness of that population. So that's something that we're starting to have some conversations with them around.
Okay, and this may be already being done, but if the 0 to 3 is where we're seeing the issue, and it's clearly having an impact, are we capable of going before with the prenatal so that we can reduce that amount?
Yes, absolutely. So a couple things here. We've launched a lot of efforts around both pre and postpartum care, and so I think our HEDIS results are starting to show some of the impact of that. We just hit the 75th percentile in both of those measures this year, which is something that's not publicly out there yet, but will be when we publish our data around that. So we are getting to some of those process measures ahead of time. The other thing that we've launched over the past about 18 months is a more intensive NICU management program, and that's specifically geared towards some of the trends we've seen around this to help support individuals and families both during that NICU stay, but also some of that transition out of the NICU as well.
And you may not have parsed it to the level, but are you able to see that some of the issue may be because of domestic? There are a variety of reasons that could create that environment, and that's one of the ones that's not really reported, but it happens a lot, which I know you guys know.
Yeah, I don't know that we have anything data-wise that helps us get to that answer, but definitely acknowledge that that's a consideration.
Okay.
I have a follow-up question. Currently, our capitation is favorable. Is there a scenario based upon the proposed Medicaid cuts that this may become unfavorable as well because it's a set amount? And as we're seeing more patients, particularly patients that may be at higher risk, is there a possibility? Is that something we've looked at, or?
Yeah, we don't expect that to be the case in calendar year or in fiscal year 2025. That is certainly a concern going forward. I would say the other thing that plays into this a little bit in the Medicaid space with the way the state set rates for managed care organizations is it's typically based on data that is 2 years ago. So one of the things that we're seeing is that a lot of the rates that are for 2025 are based on data that is from 2023 and 2022. So a lot of that still has some of the tail impacts of COVID utilization impacts with underlying some of that data. So that there's also just a lot of underlying noise happening in some of the data the state was using to set rates for 2025. So we expect some of that to help flush out as we head into 2026. But there's a lot of underlying dynamics in that.
That's interesting, because if you look at the cuts that will be coming down, that's going to remove people from the program. So county care should not necessarily experience that, but Cook County Health may experience that. It's where the impact should actually show itself.
Yes, I would agree with that. Like we may see some membership impacts from that. We don't expect that's going to be massive based on the change so far, but where that will really play out is certainly on the CCH side in terms of lost revenue from patients.
That's how we get the double impact. Right. Loss of revenue and costs go up. So it's the perfect storm.
I don't know if it's perfect, but it's coming.
And then just one final comment. Obviously, we're running at an unfavorable budget to actual here. Certainly, we've been starting to take actions as well throughout the course of the year on some cost reduction exercises. And so some of that we hope will start to, we'll see some of the impacts of that, which will help balance some of this in the second half of the year. So we have executed on a few of those things already.
What I like is when our revenue, when our expenses increase and we're over budget on revenue because, or on expenses because our revenue's also gone up. That's what I like to see, that red line. That's not the situation we're looking at going for a while. Big ugly bill. Is it big ugly bill or is it big awful bill?
Yep, and it's not really a question, it's an observation. Does this imply that if we can keep people healthy and out of the hospital, then our costs will be better moving forward, if we can do that? That's a challenge because we have no control over that. But if we can prevent people from needing or delaying their actual care in the hospital, there's a cost to that as well. That may be one thing to really focus on.
We actually do have an impact. When you say we don't have control, that's not absolutely true. There, which Aaron, I'm quite sure, can speak to very well as our chief executive officer. Yeah, I'll just leave it there.
Well, my concern gets back to this issue of the population that we are covering that has no help-seeking behavior. I mean, we see, most of the people we see are younger people below 20, and then once they get to be 50, 55, that's the majority of the patients we see. But the diseases that we're dealing with happen between that age. And the better we can do in terms of getting people to get their breast exam, getting men to go in and have annual exams, probably the lower the cost could be because we can catch things earlier. That's what I'm thinking about.
I agree.
Right. So there's a real importance of really getting people in that are not utilizing the care that's available when it's available and coming in either when it's an emergency or when they're in an advanced state of disease. That's the big issue.
Sure.
And that's I think a part of on the provider side, the transformation that we're going through right now is to focus more on a population health mindset and do that prevention, give robust care management to ensure that chronic diseases are managed and hopefully improved upon so that we don't see the strokes and heart attacks coming into ED. Instead, we're managing blood pressure and diabetes in the office. So,
Or through dialysis.
Well, it looks like, Commissioner, so, Debbie, can you add me to the roll?
Yes, I can.
All right. Commissioner Lowry, our Vice Chair, brought the gavel and his notes over to me, so I think that means he wants me to jump in. I apologize for being late. Continue.
Okay. All right, so we added a new slide into this month's reports, which will be in future reports, obviously. Just a different presentation of the income statement, the drivers anyway, which takes us on the left-hand side, the budgeted income of 3.4 to the year-to-date actual loss on the far right-hand side, which is the 62.6. So same numbers coming off of the slide that we just looked at. But again, just a different presentation. So you can see that the capitation in green on the left-hand side, and then the medical claims expense on the right-hand side, which is, obviously driving, has the offsetting impact that the capitation revenue does. So next slide, please, Debbie. Okay, so taking a look at the volumes here, so, not a lot has changed here. Average daily census at both facilities behind budget, surgeries as well. Primary care, on the ACHN side of things, 7.3% unfavorable. That gap has closed a little bit. We do, you always want to remind that we've got Belmont Cragen budgeted for the full year, which was, closed in the February timeframe. Excuse me. On the specialty care side, overall, favorable by 4.4%, which came from kind of a variety of areas, but a couple that stuck out were oral health and gynae. Our next slide, again, just showing the volumes and the trajectory over the last 3 to 4 years, and then always want to highlight the outpatient clinic visits. That top red line, which has continued to flatten. Next slide on the payer mix. So payer mix holding pretty steady at the Medicaid at 52.8%.
It changed colors.
I'm sorry?
The colors look.
Oh,
different, so I'm
new
trying to
colors.
distinguish. I only raise that because it's harder to distinguish.
Hopefully easier to see, but.
Okay.
So yeah, next slide, the revenue cycle KPIs. Just want to draw your attention to, so the accounts receivable days, which, is really a measure of the health of the accounts receivable as a whole. And we still have some of the older claims that the rev cycle team is chasing after, which is why those two boxes are still in yellow. So as those claims get cleared out, we'll be back to where we expect to be. Denied claims, so continuing to be on the right track in terms of government billing denials, and then you'll note that the net final denials, excuse me, are once again below the benchmark of 2%. Next slide, our charitable and public program expenditures. So as projecting at this point, $586 million. So of which, the two main drivers there are the charity care and uncompensated, coming in at about $385 million combined. Savings initiatives, so short by 3%, mathematically, but not concerned that we'll be in good shape by the end of the year. And the one item to note is the county care vendor contract negotiations item here will hit in July. We're just leaving it out until it actually gets done. And then final slide here, again, county care showing a loss of $21 million, but again, also showing the county care membership continues to be favorable budget. So I'm happy to answer any other questions that you might have.
I have a question on payer mix page. I was looking across at the different categories, Medicaid, Medicare, seeing the decreases or increases, if you will. And my question is on the uncompensated. When they come through, I would imagine there's a program set up to try and get them qualified for some type of health insurance. Do we have any numbers of how successful we are or are not in that category?
We can certainly pull a summary of that. We do have our financial counselors who speak to the folks who show up and say that they don't have insurance. It's verified first, and then they'll look to see if there's programs. And then if they do qualify, there's also CareLink, which is our charity care program that they would get involved in. But yes, we can get you guys a summary.
And the only reason why I asked the question is I'm trying to think of how you can decrease that category, because everything else, the money's going away, so if we can get more money where we can, it'd be very helpful.
Yeah, I completely agree. I think it's unfortunately the headwinds we're facing over the next 2 to 3 years. We're probably going to see that number go up, unfortunately.
Right. Thanks. Okay. Thanks. Just a question.
Any other questions for Scott? Hearing none, thanks, Scott.
Thank you.
The one thing I didn't miss, the monthly report on our agency reduction plan. Presented by Wynn Buren and Adam Weber. Or not. We are neither.
Sorry to disappoint.
Carrie, I'm just reading what's here.
Carrie McVogue, Associate Chief Human Resource Officer.
Never disappointed, never disappointed.
Along with?
I'm RJ Dabney, Associate CHRO. I can kick us off, discuss this.
We'll let RJ
Morning,
win.
RJ, how are you?
Morning.
I'll be correct today.
I'll be Adam?
No, you'll be Win.
Oh, okay, I'll be Win. All right, I'll kick us off and discuss,
Who's
the
on
state of
first?
hiring. I'll go first.
No, who's on first?
And then I'll kick it off to Carrie to talk about agency usage. So current state of hiring, we have had, thus far, 1,133, offers extended. We do have 840 offers accepted, so a 74% acceptance rate. So far, we do have 794 of those positions that have been filled. 580 of those are external hires, with another 214 of those being internal. In terms of separations, to date, we continue to trend downward between FY24 and FY25. Total separations declined modestly by a little less than 4%, with a notable drop in retirements, but an increase in resignations. This is minimal change in discharges. The standout change is a sharp increase in our net new hires. Our net new hires continue to increase from 129 in FY24 to 289 in FY25. So a 124% increase year over year. This is a reflection of recruitment's efforts converting agency workers. So that is why we're seeing this significant increase in net new hires. We do remain committed to reduce vacancies in order to stay on this upward trajectory. We've set to relaunch the accelerated hiring process. So just to remind everyone on the accelerated hiring process, it does reduce the posting period from 14 days externally to 5 days. And then candidates are ranked based on internal preference, and then veteran preference, and then finally agency or vendor preference. There are no interviews during the accelerated hiring process, so they meet the minimum qualifications, randomized for the preference order, and then offers can be extended based on that preliminary eligibility list. Next slide, please.
Okay, so this gives the overall representation of how we've trended downward on our agency usage from last September all the way through the end of May 31st of this year, which puts us at approximately 300 plus agency workers lower than we were last year in our efforts to decrease that agency usage. And much of that is related to our conversions that the recruitment team has implemented with the departments. But then also it has been through the assessment of each of the operational areas and ensuring that they are utilizing all their other tools outside of agency before they resort to using agency workers. The next slide actually gives more of the detail around those numbers in the graph and shows where we are. So although you can't see it on this graph, the tremendous work that the conversions as well as our concerted hiring efforts have done to reduce agency are really being borne out. As many of you remember, last summer, we were committed to decreasing agency use by 20%. And there was talk about decreasing it 20% by each classification. And as of today, from the positions you see on the chart, which are the highest positions where we do use the most agency in the organization, only 2 of them are currently above 20%. So we have significantly improved on getting the employed staff in place versus utilizing agency to cover our resource needs. Currently, we're at, the highest usage would be nursing still at the clinical nurse 1 level, and that is a fact that many hospitals are dealing with, of having nursing shortages throughout the country, and so we are competing for those same resources. So nursing is 36% of our agency usage, with the remainder being all other classifications, and we have those broken out of our percentage on the far right-hand side of the column. Any questions about this slide?
Where's the percent that says whether by classification, whether we're there?
At the 20% or less?
Yeah.
That is not on this slide. We were talking about that just this week, about how we incorporate it without it getting messy, but yes, we are looking at adding that in.
I would assume that the one that's higher is, one of them is the one we just added into the analytic code, which is the second one that is the health information management coder AFSCME position, right? So that's a new one that we're putting in the tracking.
That is a new one, so actually we don't have a good idea of what that really looks like. It would be more than the 20%, yes.
Yes, I just know off the top of my head it's higher. I just want to make sure that, I mentioned this last month, that hasn't been part of the tracking, so it's going to use some of this at some point as that filters in terms of making it look like we're making progress, and then there's this bump. It's because it wasn't part of the original data set.
Yeah, I think as we unpack contracted work like this, right, we maybe need to examine how because the solve for the other categories was very different from the second row in terms of what we're working on, the progress we're making, all of that. So I don't know if that is maybe a different kind of reporting structure. Maybe it's adjacent to this, right? But
I think it all just get equalized over time. I think now it's like we made progress. Now we're putting more things in there, so it comes back up, and it's a wave. We know that there's new currents coming into the pool.
Right.
So Carrie, I get that clinical nursing, that designation represents 36.7% of our agency use as we speak. What's been the decline within that category over the last 6 months, would you say, roughly?
Number-wise?
Yeah.
And I don't have
and percentage-wise, if you have it.
I don't have the percentage-wise. I do know that I think we've decreased by at least 40 to 60 in the last 6 months, but I don't have those exact
Let's try to
numbers.
peel that onion relative to that. I think that's a good additional stat to have, okay?
Yeah, and do you know what our usage is pegged to that 20% number now, or do you not have it? I know it's not in the table. Do you have it broken out, or?
For each of these classifications?
Just for nursing?
Just for nursing, I do not.
Okay. Well, once we get that column added, we'll be able to know it real time.
As of last month, I know we were reporting it was somewhere around somewhere between 32 and 35%. We were at.
That sounds familiar.
And I don't imagine we've decreased it statistically significantly.
Okay.
So I think last time I asked this question, but we are in the process of getting the expedited hiring process started. Have we started that yet, as far as we're doing it?
Yes, we're launching it currently. We're focused on ACHN and nursing specifically, so a phased rollout for those 2 areas, and then we'll expand it across the system.
Great. That's my next question. Yeah. Because I know we want to reduce everything by 20%, but there's another way to look at this too, actually. If we think about the impact, so we have the financial impact, we have the labor impact, and we have the operational impact. So if we look at those 3 categories, then that should drive what we're doing and how we're trying to expedite filling the vacancies. Because if we don't take that, then we're really just playing a numbers game, and it doesn't achieve the objectives. And that's what caught my attention, as Commissioner Lowry said, with the nurses, because that's got to be the highest cost, and we're excluding physicians from this analysis, if I understand this correct. So if we're looking at that, and how does that impact our ability to operate, that would help us to really put a lot of focus on getting those jobs done. Again, I could be very wrong, because I'm just looking at numbers and, the numbers that are presented before me. So just a thought and question.
Yeah, no, that makes sense. And again, that is why we prioritize those areas, especially nursing, to try to reduce the agency spend in that area. Good.
Next slide. The next slide talks about our locum tenens usage, so our non-employed providers that are brought into the organization. There was a slight uptick, which we're accounting for contract transition from month to month. Some contracts end or people leave their contracts early, and then it takes a little time to bring additional people on board. So holding relatively stable except for those minor variations.
Okay, I'll speak to the agency conversion as it pertains to the 4 settlement agreements we've had. It's essentially come to an end now. We had a total of 230 accepted offers. That was a 75% acceptance rate for the agency folks that we did offer. Thus far, we've had 216 already started. This was as of June, so there's several more who have transitioned or converted, in July. So we're essentially coming to the end of the conversion.
And that concludes our part of the report, and Dr. Franco will be talking about the tech zone.
Before you
Good
do
morning.
that, there's a rumor that for the first time in 3 years, we're under 1,000. Is that
I
accurate?
didn't want to interrupt the discussion, but kudos to the HR team. This is the first time in many, many years that we've actually gotten under 1,000 FTEs in agencies. So
I did want to interrupt. Great job.
And not because
Good morning.
we're boarding up windows. So, right, so that's right.
All right, good morning. This is Mark Franco, Chief Scientific Officer. Happy to report on the continuing progress of the grant-funded staff from Hectone to CCH. As I've reported in the past, this is being done in 2 stages. First stage was getting folks from Hectone to MEDEX. That stage was completed and led to about 97 folks getting on MEDEX's roles. That was designed to be a temporary place so that we could post positions at CCH, solicit applications, and process those applications. So on the right-hand side of this slide, we're showing kind of the progress from MEDEX to CCH. This is ongoing, but we've made steady progress over the past few months. Processing those applications, making offers, and then onboarding staff. We're expecting to complete this the second stage by the end of August. Yes.
Mark, you cut out there for a second, so if you said anything important that we missed, we have to circle back to it, all right? Just giving you a heads up.
All right. So
the project as well, and we've got the audio up, it's just not a great connection.
Okay, so just to recap, so there are 2 stages. First stage is complete from Hectone to MEDEX, and the last couple of months we've been making steady progress, posting positions at CCH for the MEDEX staff to apply for, processing those applications, making offers, and then onboarding staff. To date, we've basically posted about half of the positions, and we've got about 1/3 of the folks who've applied and received offers, and we're nearing 1/3 for those who've been gone through the orientation. We're hoping to get through this part of the journey by the end of August.
Okay, any questions? No questions on the Hectone transition. I think we got all of our questions on the rest of the agency transition. Thank you, RJ, Gary, Mark, for presenting. With that, I was fortunate enough not to sit through the procurement items, and I thank you to Commissioner Director Lowry. When Dennis was here, was Commissioner Director Dr. Dennis here.
Reverend, too.
Reverend, I forgot about that. He was also a reverend, yes, yes. I just wanna, also acknowledge my, gratitude for the recognition that that was given to, our former head electrician at Stroger Hospital, Terry Garland, that, was also, elevated to me by our board secretary, Debbie Santana, who's always thinking about everyone. So thank you for carrying the ball on that as well, Bill. And with that, we have exhausted the agenda and we stand adjourned.
Thank you.